welcome to the Voice of Nursing. Today we are very lucky to be welcomed by Dr. Raju, one of the most prominent MDs, medical doctors over in America for us with our first Voice of Nursing USA. My name is Adrian Treacy, I'm the CEO of ICG. Dr. Ram, welcome to the Voice of Nursing.
Nice to be here.
We're very privileged today to have you on. I obviously have done some research on your background and what you've been doing, but it'd be great to give us a bit of an introduction about what you're doing now, but maybe tell us a bit about the start of your career, because obviously you've got quite a unique background, having worked in the UK and the US.
Yeah, I could have picked up from my accent. I was from India, which is the southern part of India. It used to be called Madras, now they call them Chennai. Mm-hmm. I went to medical school and I finished medical school. I did a post-graduation in surgery, obtaining Master of Surgery degree. And then I moved to England. And I worked in London, I worked in Crawley, Sussex, and I got a Royal Fellowship of Royal College of Surgeons. And after about 3.5 years and I was a registrar in NHS system. Then in 1982, I moved to United States, where I just did a residency in surgery. Then I did a fellowship in vascular surgery. Then I went into both practicing surgery as well as administrative / academic part of surgery. So I was the chief of surgery in one of the hospitals. I had a faculty appointment as a professor of surgery. Then I had, I was also in charge of residency program and medical students education. I was also research director for animal research lab. So I did that for about, I would say 14 years. Then I was asked by my hospital's CEO to start a level 1 trauma center in Brooklyn, New York. So I was a founder director of a level 1 trauma center at a place called Lutheran Medical Center. Now it's called NYU Langone, Brooklyn. So at that point, I decided I came across a publication of Institute of Medicine. They usually produce these white papers. The first one was very sensational in United States because it is called "To Err is Human," which basically said for the first time in United States that 100,000 people die every year of medical mishaps, medical errors, which was shocking because the people never thought about that. Then there was a lot of debate came with that, and then that started the patient safety movement in the United States. The second one of the white papers was to cross the quality chasm, which is basically how do you creating the 21st century healthcare. At that point, they came out with what we call as the 6 aims of how the healthcare should be delivered in the 21st century. What are the essential elements of it? So the elements were quality, safety, effectiveness, efficacy, patient-centeredness, and the last but not least, the equity as a part of it. But the equity didn't get much traction. The quality and the patient safety got a lot of traction, and I didn't really know anything about equity very much. I never paid any attention to it. Then the third white paper is called Unequal Treatment. That changed profoundly my life and my journey differently. Unequal treatment showed for the first time, at least to me, that in a country like United States, the most powerful country, the most financially affluent country, the country which has got tremendous compassion, the country which has got, which leads everything in the world, there are people who do not get health care. And even when they get the health care, their outcomes are not comparable to the majority of the white American population. So I was initially shocked by that revelation, because as a surgeon, I saw the healthcare delivery through the eyes of me and my patients. I always thought that I'm a good surgeon. I never really discriminated based on either the insurance or the color of the skin or where they come from. I gave them the same treatment, which almost all the doctors in the United States and the rest of the world does. They don't discriminate their treatment based on who the patient is. And the most importantly, I was available to them. So I couldn't understand why people could not get the outcomes or the care they needed. It didn't make sense to me. That started my quest for the last, I would say, 17 years of my life. I spent on trying to search why the healthcare inequities exist in this country. So originally, I thought it's all about access. If you give them more access to care, right, that means open the clinics for longer period of time. Open them on Saturdays and Sundays, make it easy for them. These disparities in healthcare will go away. It didn't happen. So we did that for a few years, but it did not happen in the country at the national level. Then we said it is not only about access, it is also about America as a melting pot. It consists of people from all over the world. So maybe the cultural competency is an important element of the treatment. So if we can make the workforce, which is the providers of care, culturally competent to understand the beliefs of the faith and the practices of the countries where they come from, it would get better. So there was a big movement which went on in this country of training all the practitioners in culturally competent care. It didn't really work, because you cannot really make somebody culturally competent by just giving them a slide presentation for about 15 slides and about 30 minutes of training, and then you say, okay, you're culturally competent. It didn't work out. Then we said it is all about the discrepancy in the people who receive care in the United States and the people who give care. The people who give care in the United States are mostly white, and the people who really receive care are the people who are blacks and Hispanics and immigrants from other countries. So we said, if we can really make the workforce look like the patients we serve, then disparities will go away. So there was this big movement we started, somewhere in the 2008 and 9, that we need to have a diversity in workforce. So every organization started hiring chief diversity officer and trying to recruit minorities into the workforce and trying to do that. As he was proceeding, it didn't really work out. Then in 2012, it suddenly occurred to a lot of people in this country, right, which I was one other part of it, because we were in this journey trying to understand why is that. So we tried access, we tried cultural competency, we tried diversity in workforce. Then we realized it is not about the seed, it is about the soil. The healthcare, traditionally, what we did in healthcare is prepare the seed. The seed is a patient. So we give them the best care, best technology, best medications, best of everything. But for the seed to grow, you need to prepare the soil. The soil is where they live, what we call a social determinants of health. If you send an asthmatic patient who has got a great treatment and send him back to his apartment, which has got allergens like a rodents infestation or the mold, it is not going to get him any better. He is going to come back to you, because it's not only just important that you prepare the patient, you also prepare where they live and they work and they play each and every day. So that opened up a new avenue for us in saying, wait a minute, maybe we should fix the patient. We also have to look at the communities where they come from, whether they are Is a food insecurity, the inability to access fresh food? Does it affect the diabetes outcomes? The lack of public transportation, ability to reach the doctors or go and visit the doctors, is it to make a difference? Is the public safety issues preventing them from getting out of their apartment to go for a walk? Or is it the homelessness, that they don't have a stable home? Does it affect them as a part of it? So all these things are grouped together as social determinants of health. So that is where I am working on right now. Then we have literature showing that only 20% of the outcomes are dependent on clinical care. The 80% depends on non-clinical care, and 40% of the 80% is due to healthy behaviors or the lack of it. So the way to fix that is a health literacy, and the other 40% is social determinants of health. The environment, the food, the transportation, the public safety, housing stability, social system, right? Lack of mental illness, substance misuse. All those things contribute to that. So you cannot treat a patient just is diabetes alone or one's hyper blood pressure alone. You got to really treat not only the patient, not only the disease, you have to treat the patient, and we also have to figure out where they come from. So this is a new field in the healthcare right now, and probably every big healthcare delivery system have appointed people like me to study the social issues and trying to figure out how do we connect the social issues to the outcomes so that patient can do that. My famous saying was in 2012, I declared very boldly that healthcare cannot be delivered in isolation. Just delivering healthcare in isolation is like throwing seeds at the rock or in the sea. They're not going to grow. It doesn't matter how great the seed is. You got to prepare the soil where they're going to grow. So healthcare delivered in isolation is like throwing up the seeds into places which will not grow. So it does not make any sense that we do not address that. So that is my journey. So for the last 17 years of my life, I'm in the pursuing how do we create, a health system which produces the best results it deserves for all the technology, all the money we spend. How do we create that? And that has been my passion, and that's what I'm trying to do now. But it's a long way to go, because we getting the healthcare system to understand social issues when they're purely focused on the disease itself, not necessarily the coexisting factors of disease. We have a long journey ahead of us, trying to move this in a different direction.
And is this the, focusing on the prevention rather than the cure? I know you were speaking about, making sure the environment is in the right way, so then they don't keep coming back into being readmitted to hospital. You were speaking about was a bigger issue, rather than have the cure, but then they go back in again 6 months, a year later.
That's correct. I think the question will be, if you really create a treatment, the treatment has got to be sustainable. The results are sustainable. If the person is willing to help himself or herself, but the society or the social factor not allowing you to do that. In other words, you are a diabetic. You said, look, you need to have this diabetic food. The food which we recommend for you is so important. This way you're supposed to eat. You're supposed to eat fresh vegetables. You need to control the carbohydrate. Now, let's say this patient lives in an area where the nearest supermarket is 4 miles away, and he or she does not have a transportation. But in front of their apartment, there's a fast food joint available. On a cold winter day, do you think that the patient will walk 4 miles or hire a transportation and try to get the grocery shop and do the food, or he just walk across the street and get it done? So most people go and get this done because of social issues. The lack of transportation affects their ability to eat right. But the medical system usually compensates that for giving more medication. In other words, if somebody comes in, a diabetic, who is not under control, I automatically assume that my treatment is ineffective or insufficient. I need to give more medication. Whereas that's not the problem. The problem is treatment is fine, but the patient is not able to access fresh food to eat healthy.
Right.
So that is the issue. So health system always compensated for the social ills by increasing the medication as a part. So that has been a constant struggle for us. Right? How do we want to do that? And that's where the prevention comes in. The prevention is healthy behaviors. The health literacy portion of educating the patients why they need to do that, it is woefully inadequate in my mind at least. We don't know how to educate patients. Our method of educating the patients to be healthy is purely either giving them a piece of paper and say, just follow these instructions. This is your diet sheet. These are things you have to do. Or this is your exercise sheet. This is what you need to do. That's one. The second thing we do is either we give them as to some web page, go to the web page and tell you what it is. People have moved on. People get the information on smartphones. People want the real-time information. There is also a different education model. Some people learn by reading a paper. Some people learn by hearing a podcast. Some people learn in visual people. They want to see something is a video as a part of it. So, and some people want the medium different. They don't want to go to a web page. They want to go on a smartphone where they want to get the information smartphone. They also want this to be interactive. It is not one boring lecture somebody gives it to you in a web page. They're able to ask questions. They're able to interact with them. So our health literacy platform, what we are trying to design is in real time. It is given over the medium of your choice. And how do you learn better? Visual, auditory, or by reading instructions. And the ability to give you the information in your own language at the third or fourth grade teaching level. And using some animations whenever there is a need to stress a point. So these are some of the things we need to do. So if you want to do a preventive agenda in this country, we need to really revolutionize the patient education in this country. We are still far, far away. We are still following something 1950s and 60s model of patient education material in this country. And asking the patient to go to a web page and watch a video is not a big improvement, because I don't think people at the present time don't do that. They really interact through their smartphones and the reminders and the clicks and all those stuff we do very differently. Mm-hmm. But the healthcare system has not moved fast enough to understand how to communicate with the patients.
And how do you see the role of the nurse in that, in that change? Because I know you spoke about nurses being great teachers of yours. How would you see the nurse's role within that sort of communication area?
Nursing role is multifaceted. The first role is the nurses are probably one of the, in the United States, nurses are one of the most trusted profession among all the professionals. They top right at the top. In fact, they even top the clergy as a more trusted profession.
We would agree.
So nurses have a bigger role in able to communicate these things because of the credibility the nurses have earned over many, many decades. They are the best medium of trying to do these things with the patients, right? Nurses also spend more time with the patient than the physician spend, right? Because I always used to say the physician makes rounds, he speaks to the patient about 10 minutes. The other 23 hours and 50 minutes is a nurse who really deals with it. The nurse knows more about the patient and the families than the doctor will ever know or even care to know. So in the United States, when they started splitting up the doctors' rounds and nurses' rounds separately, that really created a huge gap in the information about the patients, because they didn't communicate with each other. They only communicated through the charts. And that's not a very effective way to do that. So nurses have an enormous role because of their closeness to the patients, their understanding of their needs and their situations better than the physicians, and their ability to interact better with the credibility with the patients will all be extremely important to be the ambassadors of these messages as we change dramatically the way we teach our patients. Nurses has to play a bigger role. The second role nurses play, at least in my opinion, they are the medical educators. I told you the other day, I said, look, as a trauma surgeon and ICU doc in my career doing trauma as a head of trauma, I learned more ICU medicine more from the nurses than anybody else. Nurses taught me a lot of things. Nurses told me that this patient not looking good. This patient needs that. If I do something which is not right, nurses will say, do you really want to do that? I don't think it's a good idea. But this is not the way it works. So I used to say this, jokingly in some of my nurses' meeting, that one, thank you for teaching me, right, as a part of me. And also thank you for rescuing my patients from me, because if I would not have listened to you, I would have done some bad decisions, right? Would be not a good idea. So the nurses are a huge medical educators. I don't think people completely understand that, how much they do. If a person who just comes into ICU after a fellowship of 2 years, right, and a medical school and a residency and a fellowship, can never equate with an ICU nurse who's got like 25 years experience. And that person has got the nurse has got this inner sense, or the sixth sense, saying that this patient is not doing well, this patient is doing well, and this is going to work out, is not going to work out. And that is a major component. So I think the future of nursing in the world, and mostly in the United States, is got to play a much bigger role as educators of the patients, because they have the credibility. And also as educators of the doctors and other professionals to understand how to deal and interact with the patients, understand that. And they understood that the healthcare cannot be just about giving them medication. Healthcare is also about emotional, and spiritual help with that. And nurses do that much, much better than the physicians offer emotional help or spiritual help as a component of the healthcare delivery system.
I think someone said to me it was the care in healthcare. Is that nursing element, that empathy of the patient, the understanding. So when as you say, it's spending time with, and then the ability then to coach the patients about what the healthcare choices may be, in order to. And then a lot of the nurses now are doing a lot of work in the community, especially in the UK. I believe it's a similar model in the US where the nurses are out more in the community now.
That's right, absolutely. This is a concept which came out about maybe 10, 11 years ago in the United States. We call them hospital has got no walls. In other words, the care has got to be seamless, right? You cannot have one kind of care within the hospital system and then the patient walks out, right? And then the care cannot be different, right? It got to be the same. So creating this, what we call transition in care, which has become a big buzzword in the United States, and how do we create that? More than anything else, it created for the first time a responsibility that we own the patient, whether they are inside the four walls of the hospital or the four walls of my clinic or my practice. I own them even when they are out of my system, out of my hospital, out of my building. I still have to, be connected to them, right? And that connection could be through nursing, visiting there, could be in the community. That could be through telemedicine. That could be through all those appliances we use now to track the patient. And the telemedicine has become a big issue in the United States, and Northwell is kind of leading that in the cutting edge of doing the telemedicine as communicating with the patients. So there's a huge shift in the mindset of the healthcare delivery providers in the United States, because now they assume responsibility both inside and outside their care.
And you mentioned before, obviously your background with the UK, US, UK, work in those different environments? It'd be really interesting to hear for nurses who maybe want to move between country. What, from your point of view, or from your perspective, what would you see the differences in the role in the UK and the US?
So let me start off saying with the first disclaimer, because my experience in UK is about more than 30 years ago. So I'm kind of comparing it from my time to this time, right? I enjoyed UK because I enjoyed the nurses being a part of the rounds. Right? That was a big change to me when I came to this country, that we used to make rounds and nurses were not part of the rounds. Whereas in UK, the consultant makes rounds and chief nurse was with you, and she has got exactly the same amount of power or the prestige and as a consultant, right? Basically able to deal with them. So we are going back to those kind of rounds where the nurses and the doctors, and the pharmacists, clinical pharmacy, everybody round together. That has come up after nearly 25 years of my time here, where we do our own rounds and nurses do their own rounds. And that has completely changed. So in the United States, actually went back the way it is practiced in England in the UK for many years. The second aspect is, the UK's way of taking care of, on a social medicine side, your concept of, giving healthcare to everybody without any, insurance issues or the immigration issues or where they live from, is what we call universal healthcare. Is something we are trying to emulate and trying to do in this country, right? That is a part of this Obamacare, is basically that ability for the people to be, in the healthcare delivery system, connected to it, able to deal with that. So the universal healthcare, as it appears in the United Kingdom, right? I don't know whether it will ever come in the United States. That's again my hope, but I am very pragmatic. It is very difficult. But we believe that the people are it's a fundamental right of every American, and people who live in this country should have access to healthcare. So I took a very, very strong position on that for many years ago. In fact, at some point I proclaimed that healthcare in this country should be a fundamental right. It should be a civil right. It should be a constitutional right, and not last, it is to be human rights. So, but that is more a rhetoric at the present time, because there are people in this country still, right? At one point, 40 million Americans before Obamacare were uninsured. The only time they ever reach for care is when they are deathly sick, and their care was mostly given in the emergency department. That changed a little bit with Obamacare, but I don't know, with the future being uncertain of what Obamacare is going to be, it is going to be very tough where we are going to go, right? Because lack of insurance is a big, big impediment for people keeping themselves well, right? Because if you want to create a healthy future, we need to have healthcare accessible to everybody. And I mean accessible is just not the buildings and doctors. It is people have no fear to access healthcare. The fear of not having insurance, or the fear of not having the immigration status. All those things should not stand in the way of accessing healthcare and benefiting from it.
And is there fear over the funding as well for things like Medicaid and Medicare? Is there uncertainty around that?
Yeah, the problem with the Medicaid is a state program.
Yeah.
The Medicaid is the problem Medicaid is, the problem Medicaid is the eligibility of Medicaid is different in different states. There are some states which are very generous in the Medicaid eligibility, and there are certain states which are very strict. There are states in the United States where you get only Medicaid if you are somebody who is under the age of 18, or you're pregnant, or you're disabled. So if you're working poor, if you're poor, that does not mean that you'll get Medicare automatically in some states. In some states you do. But if I am poor, if I can't afford to pay for it, I tend to postpone my treatment longer and longer. So till I get extremely sick, then at that point I go to the emergency department, where then the care is basically underwritten by the government. But that is more expensive care. A 20 cents of diabetic pill given free to the patient is probably better than paying for his dialysis because the diabetes killed his kidneys, and paying for diabetes 3 times a week for next 30 years. So some of us believe that giving them more access, giving them ability to universal healthcare will probably reduce the healthcare expenditure in this country. But healthcare in the United States is a huge political issue. The reason it's political issue is because so much money is in it. It is not necessarily anymore a doctor and a patient or a nurse and a patient anymore. That is a very small portion of healthcare. There are other varied interests, pharmas, medical device companies, insurance companies, healthcare delivery systems, specialty associations, right? Lobbyists, everybody comes into this pie. So they all want their pieces of pie. So when you have 30 or 50 different interest groups trying to manage a healthcare delivery system in this country with the amount of money, it is very difficult to reach a consensus. And because what is best for the patient gets lost in the interest of the industry sometimes overtakes than the interest of the patient, unfortunately.
This must be quite a challenge for healthcare professionals, nurses and physicians then, if they've got patient-centered care. So they're thinking that the patient is the decision maker essentially if you have the other parties involved. It's quite challenging.
Yeah, absolutely. There is a growing movement in the United States trying to say, how do we put the patient in the center of all the decision making? And we are trying to do that in a much more effective way, but it is, in my opinion, is long overdue. We should have done that many years ago.
I think we're all working on that one. One thing I'm interested here for you, how have you sort of seen the relationship between physicians and nurses evolving in the US?
It is definitely getting better and better because because of the evolution of the nurse practitioners who came in, who practice as a primary care caregiver in many instances. So naturally that thing kind of closed the gap a little bit over a period of time. And there are nurse anesthetists who really do these things. And there is a lot of things which are coming up as an organization. So it is, but still, a lot of them are territorial factions exist, right? There is a concern how much a nurse practitioner can do as opposed to a doctor. What should be done? In some states, still the nurse practitioners work under the doctor. In certain states in New York, there you really don't need a doctor supervision. You are an educated professional, you can't do that, you can practice. Then there is a prescribing, whether nurse practitioners prescribe. Now we say they can prescribe on their own. In the past, they used to be countersigned by a physician. So over a period of time, the nurses are being more and more empowered in the United States compared to 10 or 15 years ago. But that is not a smooth ride. There's a lot of interest. Having said that, I just don't want to say there's only between nurses and doctors. Even between the doctors, between specialists, there's always a territorial war, right? How much a podiatrist can treat, how much, can he treat something wrong with the ankle, or he should be an orthopedic surgeon. Who takes care of back surgery? Is a neurosurgeon or orthopedic surgeon? Right. So those kind of territorial things happens, right? As an organization, because the healthcare has got a lot of money in it. So when there is a money, people want to very jealously guard their territory. And now the nurse practitioners are filling into the territory. There's always some consternation. But most of the country, most of the doctors have agreed that nurse practitioners play an important and effective and efficient role in the United States that need to be encouraged, and should be supported. And that is a prevalent opinion right now of the healthcare practitioners in the United States. So I would say it got much, much better. And the relationship is much better now. We see as equals, and we depend on them to provide care. So at least in the healthcare delivery systems, like in Northwell, the largest healthcare delivery in New York State, the nursing given almost equal prominence as doctors are. The head of ICU nursing gives the same weightage as the head of the ICU in hospital. So that has got much, much better over a period of time. So, and that is good. I believe the nurses and doctors respect each other, work together with each other. The patient gets the benefit of it. Exactly. It is always, as opposed to undercutting each other. Oh, who told you that? Oh, nurse, forget, she's a nurse. That kind of discussion does not happen anymore. It used to happen 20 years ago, but not anymore in the United States, because we learned to, we understood the importance of nursing and how important they are towards the patient care in this country.
That's really good to hear. And what do you see, Dr. Ram, from the main sort of trends over the next 12 months in the US from a healthcare industry point of view?
United States healthcare industry is in a turmoil because we do not know, because politics controls the healthcare in this country. There is a little bit of factional politics right now. It's playing out in the United States. There's a lot more. The people are not working together now. Right now, there's big two factions. They really have totally different opinions of how do you do that as a part. So 12 months is a kind of short period of time. We don't know how it is. It's a very kind of fluid situation in the United States. But in the long term, I believe that the trend of moving away from inpatient to outpatient, moving away from sick care to preventive care, health care, because in the United States, like everywhere else, we only practice sick care, what I call rescue care. We know how to rescue patients quickly, but we don't know how to keep patients healthy. So that shift is happening, right? From inpatient to outpatient, from rescue care to health care, real health care, from nurses being as a subordinates, but nurses being equal partners in the outside part of it. Understanding the social issues together with the healthcare issues. All those things are coming up, right? And that is a future will shift towards that, treating the patient as a whole. That is a patient-centeredness. When you talk about patient-centeredness, it is not just giving this care to the patient-centered. It is understanding the patient and bringing in all the things, the healthcare and social support system, together to create a healthy individuals. So I think in the next 10 or 15 years, it will move towards that. But 12 months is a kind of, first we still have to figure out, we are spinning so much, we don't know which way it's going to end up. Mm-hmm. But whatever ends up, it's going to be very temporary, because it's just going to, eventually the forces of the doing the right thing, the smart thing, it is going to prevail, and people will get what they need to do that. So that cannot be stopped. It'll go in the right direction. But there are two issues. One is we all agree how the care should be provided. And that is not much of a discussion on that. Everybody agrees. But our major discussion right now is who should pay for it, and how much the government should pay, how much patients should pay. And that is the discussion which is kind of, factionalized to a great extent by the two different groups in the United States at the present time.
And you mentioned about the turmoil and also the pressure that healthcare professionals are under at the moment. One thing that's been very prevalent in the UK is about the mental health issues of our actual healthcare professionals. Because one thing we've noticed, nurses are great looking after the patient, but sometimes who's looking after the nurse?
Yeah.
And mental health has become a big issue in the UK. And from what I understand, it's being looked at in the US quite heavily as well.
On the provider side, mental wellness of the providers, you mean nurses
Of
and
the
doctors.
mental health of the nurses and the doctors, yeah.
Yes. I think that is a big issue for us. We call them the fatigue factor, right? And that is a big issue. And what we call as a burnout, the physician nurses is a very big issue because the things have changed. Because of the nature of the healthcare's innovation, the people who would have died of a particular condition 20 years ago, right now are being treated and with a great success. So it puts a tremendous amount of pressure. It's not the ICU of 1990s, right? ICUs in 2018 are some of the sickest patients you can ever encounter in your life, which would have been dead 20 years ago. But that simply means there's a tremendous amount of work need to be done with the physicians and the providers. And the pressure of the financial pressures, the pressure of the government, the pressures of regulations, and the major factor in the United States is a malpractice claim. The pressure put in by the trial lawyers. All those things, and the pressure exerted by the EMRs, which are coming up, and the doctors of my generation finding it very difficult to quickly adapt to that as a part of it. All these things are producing a tremendous amount of pressure on the providers, nurses and doctors. So the burnout is extremely concerning to them. Either they're retiring prematurely or they're leaving the profession, or some of them are leaving the clinical care and moving to non-clinical jobs. So we have a problem. Our problem is that we have an aging population, and we have baby boomers who will live longer than the previous generation. We do not have enough healthcare providers to take care of them in the future. Because the rate with which we are producing the nurses and PAs, physician assistants, and the doctors is not keeping pace with the number needed to take care of the American population, because baby boomers living longer and longer, and they also living more healthier compared to the previous generation. So it has been a huge issue for us. So we are trying to encourage the United States to open more nursing schools, train more nurses, more doctors. New medical schools are opening up. This class sizes increased over a period of time. All those things are a major factor. One other factor is also, which is important to understand, is the medical debt. Medical debt or the nursing debt. When they go through a medical or nursing school, they incur so much of debt, and they work for a long period of time to pay that back. So there are some governments at state level come in with some kind of relief on the debt. In the past, the relief on the debt used to be that you go and serve in an underserved area for X number of years and we'll forgive your debt over a period of time. But now people are really looking at it much more differently and saying, how do we really create an environment so that they are not burdened, the emotionally distressed about the debt part of it. Mm-hmm. And that is another thing, because it's so expensive. With the reimbursement system going down, especially doctors are finding it very, very difficult to repay the debt over a period of time. And that debt factor also forced people to go into highly lucrative specialties to pay back the debt in a shorter period, as opposed to doing primary care where you don't make much money and your debt lingers on for a longer period of time as a part. So these are some of the social, financial issues we deal with in this country, which creates a burnout and mental health issues for the doctors and nurses and other providers. And I'm very happy to say that the country as a whole has started paying a lot more attention to it in the last few years and trying to figure out how do we support them the best way possible. Because we do not want our providers either, get burnt out or get into mental illness or use substances to create a better, psyche or mental wellness spurious or mental illness for them, mental wellness for themselves, depending on drugs. So we are very cognizant of that, and that's another example that we are looking at as a profession as a whole, not just to look at skill and knowledge. We also look at their social and emotional stability as a major factor.
Yeah, it's good to hear that. Actually, think about the outside factors. It's a very pressurized job at the best of times it can offer a patient. You don't think about all the additional, being in debt, or how they keep going with the amount of hours that a lot of the the healthcare professionals work and what have you as well. And obviously talk about supply and demand. What impact do you sort of see technology having? I know we've obviously made great gains over the last 10, 15 years in regards to that. Is why baby boomers and people are living longer and being healthier. Some of those technology advances might help us moving forward if we haven't got as many healthcare professionals.
No, I don't believe that we don't need more healthcare professionals. I think the jobs will change. The skills they need will change over a period of time. They were very good in, let's say that they are more interested in examining patient individually. Now they should be able to interpret the patient condition through telemedicine.
Okay.
Right? They need to understand that. So I think the workforce composition, healthcare workforce composition in USA will change. We have to really read them new skills, and some of the old skills are not very effective. Now I can quote my own example. I'm a vascular surgeon, right? I spent probably close to 20 years of my life in perfecting my technique of putting a blood vessel to a graft, because that was a treatment. If there's a blockage, we used to do grafts. We would bypass the graft. We call them bypass grafts. My entire time I spent on trying to perfect the technique so that when I finish the operation, the suturing is perfect. It doesn't create any turbulence in the flow. It is smooth. It doesn't leak. It has got a good thing. Overnight it changed. Now we just have stents. If you see a blockage, you go there with your rotor and then you just open that and put a stent and walk away. So if I go and apply to somebody and say, Ram, I want to do vascular surgery. If they say, what is your skill, Ram? I said, I do the best anastomosis possible. They'll say, no, we don't want you. We want somebody who knows how to use the catheters and put a stent in place, right? So the skill level changed. It changed. People who do open surgeries have moved on to laparoscopic surgery. People have moved on, open craniotomies have moved on to stereotactic surgery, right? Everything has moved in a very different directions. So we need to understand that. And so the skill level, and that has happened in my time, it happened over slowly, but now it's happening very fast. Every 5 years, the skill you need to be good in your profession are changed. Mm-hmm. It needs something else. Something new comes up, right? And they are able to do that. So those are some of the essential elements. I don't believe the number we need more providers, but we want different providers. They're not the same providers. We train somebody. So healthcare system, especially Northwell, has understood that, because in healthcare, we tend to replace, when somebody retires or leaves, we replace them with somebody similar. We all realize that if we keep doing it, then we will have the workforce like 1980 with the new people in it. But now we realize that as every job turns over, we said, do we need this job? If we need the job, what kind of skill levels we need for the future? Mm-hmm. So the workforce re-engineering and workforce development is a major factor in this. And I was in the national committee of predicting how the workforce should look like in the future. So we came out with some ideas. What are the skills you need, right? Because it is so important that nursing skills are different, right? If you are really going to shrink the inpatients side and you're putting outpatient expansive, you cannot create overnight an inpatient nurse who's a surgical nurse inpatient side suddenly become community nurse. Two different skills.
Yep.
So we need to figure this out, how to do that. People always say, oh, it's not a problem. We shrunk the bed from 500 to 300. So we have 50 inpatient nurses available. Why can't we just put them in ambulatory care? You cannot, because their things are very different. Same way, ICU nurse may be different from a dialysis nurse. Or a med-surg nurse, medical nurse will be different from rehab nurse. A rehab nurse cannot do OR nurse. So there is a lot of specialization. So we need to really be very, very cognizant of how the trend is. Where do you want people? And what skills they need? Mm-hmm. Some are shrinking areas, some are expanding areas. And we need to figure out, a diabetic nurse is probably an expansive area because there are more people who we expect, unfortunately to turn diabetic because we have a large number of pre-diabetics in the United States waiting to get diabetes. So that is a good area. In some areas where there is an open, bowel surgery, the ORs have shrunk over a period of time. More and more surgeries become ambulatory. More and more surgeries are practiced in outpatient centers. More and more ER cases are moving into urgent centers, not in the ER anymore. And more deliveries are being conducted in the birthing centers.
Or at home.
So over a period of time, you're going to change that, right? So it has got to be, so I think both medical profession and the nursing profession need to project what is needed in the future, what kind of skills we need, and try to prepare.
And have you got any recommendations for if new nurses are going into the field now? Is there anything you'd recommend with a bit of, I know can't give too many secrets away, but just a bit of foresight?
No, we are concentrating on selecting the nurses and putting them through the programs. We have these programs in our system of trying to equip them with the right skills for the future. So we are training more and more nurses in telemedicine. We have nursing in community medicine, in social determinants and preventive health kind of stuff as a part of it. We're using nurses as ambassadors to our communities because they are well respected. They have enormous credibility as a part of it. And there are areas in which we need more nursing. These are highly sophisticated areas like we have this cancer surgery is highly sophisticated right now. Chemotherapy has become much more effective as a part of it. That's the thing, because the chemotherapy we used to deliver inpatient is now delivered at outpatient. Home care is becoming a huge issue. Is a need for it in the future. So taking care of a patient at home is a very different skill from taking care of a patient in a hospital setting, which is much more controlled. So I think we are quite aware of what is needed, and Northwell is kind of understanding this and moving this in a way forward. And our chief nurse executive is extremely innovative and thoughtful how she does things, and she has done a phenomenal job of preparing nurses. So if you just keep giving them same curriculum one after another, and we do that, it will not be good. So the existing nurses, we have a very, very robust clinical CLI, which is a clinical learning institute. We spend a lot of money on this. So we put the nurses through those education, whatever needed, and the skills needed over a period of time, so that Mike Dowling, the CEO, is basically, saying that we need to be a learning organization. The learning never stops. Whenever you learn something and perfect something, that's the time it is time to lose that and get another training, because it changes. It changes very well. So holding on to the things we have done in the past as the only way I know how to do things has changed, right? So we are very innovative. We are constantly looking at the future and say which is coming in, which is not coming in. And we not only shape the future to some extent by our advocacy and our policies and our the way we speak to at the national meetings, but we also understand what other people are doing and try to keep one step ahead of everybody, because it's a very, very competitive business in the United States, especially New York market.
And tell me a little bit about the Northwell Reach for the Stars program.
Yeah, the question is it is based on the concept that we have to reach for stars all the time, right? So whatever the scores are, whether it is a 5-star rating, we always want the 5-star ratings. In the patient experience, patient satisfaction, in quality, patient safety, right? Our ability to deal with social issues, right? All those things we want to be at the top of it. So we wanted nurses to always aim for the stars. Right? We just don't want them to do their job effectively and good. We always want them to reach something bigger than that. So we involve them in every one of them. If you're quality, we involve them in that. If it's IT, nurses are involved in IT innovations. If you have ventures, we are looking at new innovations, we have the nurses involved in them. So the idea is, as a Northwell reaching for the stars, the 5 stars, which is the 5-star is the highest award you can get in the United States, and every hospital is being graded on star system and various specialties, which is hospital good in cancer surgery, which is good in heart surgery, which is good in orthopedics, who is good in diabetes, who's good in so all those things. So it is basically telling the nurses, look, we continue to reach for stars. We will not be happy till we get our 5-star. Even then, we will not be happy because we want to keep the 5-star. Because once we are complacent about it, then the star rating drops. So it is an involvement and the inspiring for the nurses to do what needs to be done as an organization.
That's good to hear that you're planning ahead. I'm sure you'll get the 5. I'm sure you'll get the 5
No,
stars.
I think most of the hospital systems in the country are planning ahead because the things are changing extremely fast, and we need to be tuned with that. Otherwise, if you don't innovate, in the 1 year you will be far behind.
Yeah, if you're not moving, you're dying.
That's right. If you're not moving, you're going backwards. That is the concept. You got to keep on moving, and we keep on moving on that. And I'm trying to keep moving this social justice agenda into the thing. And I also, at the present time, Northwell is also involved in not only improving the health equity and social equity. I also believe the social equity will not come unless it's economic prosperity. So the healthcare organization, Northwell, like a $12 billion corporation, we are the economic engine for the areas we serve. We hire locally, we give jobs. We give out contracts locally for everybody to fix things in my thing. We buy things locally, right? So all those things are really an economic growth in that area, right? It gives jobs, gives a part of it. And I believe that we need to continue to use our economic power to produce economic wellness in those communities. If there is economic wellness, the social equity comes in. Then the big stores come in, because there are some areas in the country where the well-known stores don't want to go there because there is social issues, there is safety issues. That change. When the job comes in and the people are well, they're able to buy things, the consumer market improves and people come in. Once the big companies come in and put their shops over there, the entire complexity changes. And that shops gives the jobs to local people. So we are really, moved from health equity to social equity to economic prosperity. So now I am convinced the last 1 year and a half saying that if you use your economic power to improve the economic prosperity of a community, the social equity comes with that. The social equity improves health equity. That is the concept. So we cannot be seen as a healthcare leaders. We got to be seen and play the role as social change agents. That is the new mantra. as we train our administrators, the future, building them the future C-suite roles, we insist on it is not good enough just you know how to manage a hospital. You need to be a social change agent. You need to feel what a community needs, what is needed to be done, and you need to advocate for the change. Some of them you can do it yourself. Some of them are too big for you to do it, but you could be an advocate because of your position as the C-suite executive Northwell, the largest healthcare delivery system in New York State. You have the power. You have the ears of the legislators. You have the ears of the governors and mayors. We can say, look, we want this to improve. This area does not have transportation. I want this to be changed. This public safety issue over here. I want more police in there. So we have to really step beyond our role as purely, hey, I only know how to treat your diabetes. Don't bother me with anything more than that because I am not interested. That days are gone. It's gone.
It's really good. Different. It's really good listening to you to hear the passion you have for that, but also how as you say, it's bringing the awareness to people in the C-suite, so they can affect those changes, and that actually there's a trigger mechanism, isn't it, that then goes into the healthcare system.
That's right.
The prevention is really interesting. Ram, I know how busy you are, but what do you do outside of work? Do you ever get any time off apart from winning many awards and helping us all?
Now I speak in a lot of meetings, keynotes, and commencement speeches, everything else. That is a part of. Though it's a part of work, I actually consider that as more of a thing. And I'm actually involved in my community. I sit in the community advisory board, and I'm worried about environment. And I sit in the land use committee, making sure that we expand with the awareness of the environment before we do that. For personal enjoyment, I bike. I'm a biker. I love to bike all the time. I really spend a lot of time.
Is it cycling or motorbikes?
Huh?
Cycling or motorbikes?
Not cycling, not motorbikes. Okay. Where I need to expend some energy and keep myself fit. And I read. I am a great avid reader of American presidents. It's about Civil War. Mm-hmm. And I really read about not contemporary politics. I'm more interested in American politics and history for many years. So I probably consume, I would say, at least 2 books every week. So the work at time, and I have this audio books which I listen and when I bike and when I. So those are some of the things. I spend time with my family and things in there, but I spend a lot of time in social issues in my community, making sure that people are taken care of. Fantastic. And people don't do things which they're not supposed to be doing.
You don't treat it as a 9 to 5 job.
But they're not always successful, but I still keep trying.
Nothing wrong with that. As long as you keep trying and keep fighting, you're okay. But Dr. Ram, thank you so much for your time today. Thank you to everyone watching The Voice of Nursing. Thank you to all our nurses, our doctors, our physicians, our healthcare professionals for looking after us. And thank you again, Dr. Ram, for taking the time.
Thank you for this opportunity. I really enjoyed it, and best of luck in what you do. And please convey my excellent regards to the nurses of United Kingdom, because they had a hand in shaping my career when I was very young, and I was a new guy in United Kingdom many years.
We will indeed.